What's up, ladies and gentlemen? Welcome back to another episode of the StormCast. We are live on Facebook, YouTube, and Twitter. So if you're not tuned in, go ahead and follow those links down at the description to get updated when we go live. Today is Friday, January 5th, and it's a crispy 50 degrees outside. I hope everyone has had a great week. As we enter the new year, I want to say Happy New Year. 2024 will be great. Stay strong and remember the goal. Shout out to all the new subs on YouTube. We're almost at 2,000 subscribers. So thankful for y'all. And also shout out to all the supporters on Patreon, new uploads on Patreon. And so just also hit me a message on there if you want to get special behind the scenes content. Channel stats. Right now, guys, we are at 92% not subscribed watching on YouTube. So we definitely got to change that by next week. If you're watching this and you're not subscribed, go ahead and hit that subscribe button. Let's change that stat. Shout out to the new countries tuned in. We got Indonesia, Brazil, Germany, and the UK. So shout out to all my foreign watchers. And we got 53% male audience right now. So that's different than normal. It's usually at about 60% female audience, and now we're mostly male. So things are changing. 60% of the viewers are aged 25 to 54. So we got a pretty mature, high Q audience going on right now. Shout out to the chat watching. If you do watch this right now, go ahead and drop a comment on the live replay. And if you're tuned in right now to the live chat, go ahead and throw a W in the chat. Let me know how your day is going. Topics for today, we're going to be talking about proprioception, psilocybin, and a microdosing study, cannabinoids and neurogenesis, and everything neuroscience and health. A little personal news. Supposed to be going to the Krieger coming up here soon. So we'll see if that is going to actually happen. And I'll keep you guys updated if it does end up happening here at the end of this month out there in Maryland. It's a nice little trip for me, but they should have some good therapists, physical therapists, and occupational therapists, as well as doctors that know about spinal cord injury and all things recovery. So that'll be some good content to get and share with you guys. Also, I'm trying to get my independence still working on moving out and getting another house where I can grow and pretty much continue the empire and the channel and continue to grow physically, mentally, socially, and grow as a man, be out on my own. So I'll also keep you guys updated with that. So as far as the topics today, guys, I want to jump into proprioception and the awareness of the position and movement of the body in health and recovery. So we're going to discuss the effects of proprioception training and the role of proprioception for individuals recovering gait and movement, and look at the role of proprioception in motor recovery after spinal cord injury. And some examples of proprioception training and exercise protocols for people after spinal cord injury. So this should be good for anyone watching that has a disability and wants to relearn basically how to feel and learn how to move again. So that's going to be a little thing we react to right here. So I'm gonna go ahead and throw it on the screen for you guys watching. And if you do join, throw a W in the comments for me. Let me know how your day is going. So this is the sensor motor effects of a lower limb proprioception training intervention for individuals with a spinal cord injury. So we're going to jump into the abstract right here. Proprioception is critical for movement control. After a spinal cord injury, individuals not only experience paralysis, but may also experience proprioceptive deficits, further confounding motor recovery. The objective of this study was to test the effects of a robotic-based proprioception training protocol on lower limb proprioceptive sense in people with incomplete spinal cord injury. A secondary objective was to assess whether the effects of training transferred to a precision stepping in people with motor incomplete spinal cord injury. Participants with chronic incomplete spinal cord injury and able-bodied controls underwent a 2-day proprioceptive training protocol using the Locomat robotic exoskeleton. The training involved positioning the test leg to various positions, and participants were asked to report whether they felt their heel position, endpoint position, was higher or lower compared with a reference position. Feedback was provided after each trial to help participants learn strategies that could help them discern different positions of their foot. Changes in endpoint position as well as knee joint position since were assessed pre and post training. We also assessed the effects of proprioception training on the performance of a precision stepping task in people with motor incomplete spinal cord injury. Following training, there were significant improvements in endpoint and knee joint position sense in both groups. The magnitude of improvement was related to pre-training baseline proprioceptive sense, indicating that those who initially had better lower limb position sense showed greater changes. Participants also showed improvements in performance of a precision stepping task. So that's pretty much the abstract and the study that took place. A little introduction here. We're gonna skip the introduction actually. Well, no, we'll briefly talk about it. So we'll introduce proprioception, which is, of course, again, the sense of position and movement of the body and limbs in space. It's critical for movement control. Following the spinal cord injury, individuals may present not only with muscle weakness or paralysis, but also somatosensory deficits, somatosensory deficits, and proprioceptive sense, I should say. This has implications for the recovery of motor behaviors post-injury that will impact daily activities, including balance and walking. Proprioceptive sense has also been shown to be related to functional independence, such as in dressing and grooming in people with stroke. Most neurorehabilitation strategies have focused on improving voluntary control and strengthening motor output through active interventions, such as functional electrical stimulation or body weight supported treadmill training. The training concepts underlying many of these strategies focus on eliciting and strengthening motor function. In contrast, recovery of sensory function is typically not a direct focus of rehabilitation strategies. So the purpose of this training is to get back sensory function, which is feeling. Not specifically on movement, but it'll have you be able to better feel limbs and body parts, which will also help you in turn with functional activity too. So walking and grabbing, holding, and using tools to be more independent. So we're going to move down here and look at some of the protocols. We're actually going to skip these protocols and kind of get, because a lot of this is pretty much just talking about outcomes of patients when using different training. So we're going to look at the results and see exactly what the position is of this article and see all the benefits you can get from doing proprioceptive training. So let's scroll down here a little bit. And if you're watching this live, let's see how many viewers we got. So right now we're up to 1 viewer, and that is more than no viewers. So we're gonna say shout out to the comment as well in there. NZA, shout out to you. Do me some emojis. Appreciate you. NZA. Okay, now we got the conclusion. The study demonstrates that it is possible to enhance lower limb proprioceptive sense in people with incomplete spinal cord injury. Effects transferred from an endpoint training task to joint-based proprioceptive sense, and also to perform in a precision stepping task. Further studies that needed to determine the dosing for long-lasting effects of such passive training. Interaction effects with other activity-based therapies, as well as effects on rehabilitation outcomes and functional mobility. So the underlying neural mechanism driving proprioceptive changes are unclear, though. However, it has been postulated that changes in proprioceptive sense following the type of training we employed here is likely the result of alterations in central nervous system activity, rather than changes in neural firing of the peripheral receptors. When individuals learned a reaching task under force field perturbation of the upper limb, showed that there were subsequent perceptual changes in proprioceptive acuity. However, if participants experienced identical reaching movements, but only through passive motion, no such proprioception changes were seen, demonstrating that passive movement alone, manipulating only peripheral receptors, cannot result in proprioceptive changes. In our study, although our proprioceptive training involved passive movement, it was paired with a forced choice protocol and visual feedback, therefore actively engaging the participants. As such, it is likely that the effects we saw here, although short-lived, were associated with alterations at the level of the central nervous system. So there are neuroadaptations seen after doing proprioceptive training. And so, for example, when subjects receive visual feedback about the location of their arm while they're taken through a passive movement trajectory, they were able to reproduce such motions and also showed improved proprioceptive acuity. Okay, so the role of proprioception in precision walking tasks. Most gait rehabilitation interventions for people with spinal cord injury have focused on strategies to improve voluntary control and strength to enhance community ambulation. A primary mode of rehab is intensive walking practice, with or without technological assistance. While these approaches are promising, their purpose is targeted toward strengthening motor output, and assessments of their effects tend to focus on gross measures of walking speed and endurance, the neural recovery of more complex walking function, requiring more intricate sensory motor control, and it's less well understood. So this journal, written by the Journal of Physiology at physiology.org, pretty much discusses a few things here. It talks about the development of a robotic-based proprioception training tool to lower limb proprioceptive sense. The results indicate that both endpoint discrimination using a heel as a reference and knee joint position sense could be improved after a small dose of proprioceptive training. both in individuals with spinal cord injury and able-bodied controls. Moreover, performance in a precision stepping task also improved after proprioceptive training in the spinal cord injury group, indicating transfer effects of the training to a dynamic task. As unexpected, both groups can benefit from proprioceptive training. The extent improvement was associated with baseline proprioceptive sense, where individuals who had greater deficits in proprioceptive sense showed larger improvements in knee, joint pain sense following training. I think that's what JPS stands for, I believe. Lesser improvements were observed if knee proprioceptive sense was already good, even though training was tailored to each subject. So by doing dynamic tasks, you can benefit from proprioceptive training. The extent of improvement was from baseline. There was larger improvements in being able to feel your knee and your joints as compared to before doing proprioceptive training. So we're gonna stop sharing this, go back and see what's going on with the chat, what's going on. BMU D-Luck, shout out to him in the chat. Shout out to you. What's going on? He says putting in work. Yes, sir. Always. You know how we do it, man. So we're going to look at this next article that I saw, pretty much describing some of the same things, but the way they described it is with electrical stimulation to the spinal cord, and how it connects with proprioceptive training. So let's go ahead, and he says a lot of info. Yeah, man, I'm doing a lot of research right now. And so just pretty much learning about how different recovery mechanisms can affect you in different ways and how you can use it in your life. So I hope it can be useful as well to you watching. And you really don't even have to be disabled or have an injury for these type of training modalities to benefit you. So anybody can benefit from doing recovery type training. It would actually be good for you neurologically to be training in this way, if you want to preserve your health and remain well. So this is from the Nature of Neuroscience, published in October 31st of 2018, talking about electrical stimulation to the spinal cord. Electrical spinal cord stimulation must preserve proprioception to enable locomotion in humans with spinal cord injury. So this is going to allow people with spinal cord injury electrical stimulation to be able to better recover proprioception. Epidural electrical stimulation, or EES, of the spinal cord restores locomotion in animal models of spinal cord injury, but is less effective in humans. Here we hypothesize that this interspecies discrepancy is due to interference between EES, or epidural electrical stimulation, and proprioception information in humans. Computational simulations and preclinical and clinical experiments reveal that EES blocks a significant amount of proprioceptive input in humans, but not in rats. This transient deafferentation prevents modulation of reciprocal inhibitory networks involved in locomotion and reduces or abolishes the conscious perception of leg position. Consequently, continuous EES can only facilitate locomotion within a narrow range of stimulation parameters and is unable to provide meaningful locomotor improvements in humans without rehabilitation. Simulations showed that burst stimulation and spatiotemporal stimulation profiles mitigate the cancellation of proprioceptive information, enabling robust control over motor neuron activity. This demonstrates the importance of stimulation protocols that preserve proprioceptive information to facilitate walking with electrical epidural stimulation. So basically what that's telling us is that the importance of stimulation protocols basically preserve proprioceptive facilitation in people with disability learning to walk again. But it's important to realize that you should be exercising as well as performing this type of stimulation to your spinal cord if you want to get maximum benefit. Okay, so little short article there I thought was interesting. And so I want to go ahead and move on to another one, which explains proprioceptive training protocols for people with incomplete spinal cord injury. So this is gonna be helpful for people with incomplete injury as compared to people with complete injury. As we know, the two different injury levels for the spinal cord are incomplete, and incomplete. There is going to be a level of information bypassing the level of injury. And complete, there is a complete severance of the spinal cord, leading to no level of connection or past the level of injury. So this is a article from icord.org edited by Rona Herzog. And in 2019, researchers from icord studied a new passive training protocol that used the local mat robotic gait device as opposed to many neurorehabilitation strategies that focused on active interventions, including inducing and strengthening motor function. The training protocol used in this study was passive. The passive intervention focused on the recovery of sensory function in individuals with spinal cord injury. Specifically, this training protocol was designed to recover proprioception. Proprioception refers to our ability to recognize the position and movement of our body, and it plays a critical role in human movement control. The studies of this objective, there were two main studies. The first one was the main objective, which was to test the effects of the researchers' proprioception training protocol on lower limb proprioceptive sense in people with incomplete spinal cord injury. And the second was this to access the whether or not the benefits from training transferred to a precision stepping task for people with incomplete spinal cord injury. So we're going to be largely focused on individuals with incomplete spinal cord injury. And the training protocol was focused on improving two aspects of proprioception, which were endpoint discrimination and knee joint position sense. For the endpoint discrimination task, the local mat moved one of the participants' entire lower limb twice, resulting in a change of the participant's heel position. The participant reported if the final position was either higher or lower relative to the starting position. And then for the second training protocol, the knee joint position sense task, the local mat flexed or extended the knee, and the participant had to position the knee back to the starting position using a joystick to control the local mat. Visual feedback was provided for learning after each response in the proprioception training. After the proprioception training, the participants performed a precision stepping task where they walked on a treadmill and trained their ability to raise their foot to a target height during the swing phase. So, how was the research conducted? It resulted 15 participants with incomplete spinal cord injury and 10 able-bodied participants. Participants with incomplete spinal cord injury were asked to determine the leg for which they had greater difficulty sensing position. This leg was then used in the training protocol. For able-bodied participants, their non-dominant leg was used. Before the training protocol, all participants accessed the baseline ability to sense their knee, joint position, and heel position. For the participants who were able to walk safely to some degree, researchers also assessed their ability to carry out the precision stepping task on the treadmill. The participants used the training protocol over 2 consecutive days to improve in the 3 tasks. Researchers tested if the participants improved their scores after the training protocol was completed. So after the research, researchers found that both endpoint discrimination and knee joint position sense could be improved after a small amount of proprioceptive training. The extent of individuals' improvement was related to their proprioceptive sense prior to the training protocol, where individuals who had larger deficits in proprioceptive sense showed larger improvements following training. The results also demonstrated that improvements in proprioceptive sense transferred from the endpoint discrimination task to the joint position sense task, and also the precision stepping task. So why is this important? The findings of this study indicate that passive training was beneficial and had potential to become a rehab intervention alongside the other protocols focused on improving limb strength, walking speed, and endurance. This matched results from previous studies that also demonstrated the possibility of training an individual's ability to sense the position of their limbs, an ability that has importance in precisely controlling the path of the feet while walking. Researchers note the importance of further studies in order to determine the long-lasting effects of such training, interactions with other therapies, and effects on rehabilitation outcomes. So this is important for recovering sensory function after spinal cord injury for people with incomplete injury, and the ability to perceive and interpret the world among us while walking or sitting in your chair and learning to walk again. It's important to be able to focus on where your body is in relation to where your surroundings are. So we're gonna stop sharing this screen and we're gonna move on to the next tab that I want to react to here. And this one is a video. So I want to go ahead and put it on the screen for us and react to it. It's explaining exercises that improve proprioception after spinal cord injury. So shout out to Zebrafish Neuro.
Hi everyone, Stephanie here. This week's tip, we're talking about proprioception after spinal cord injury. So first, what is proprioception? Proprioception is sometimes referred to as our sixth sense. It's our ability to feel our body or our limbs in space. So essentially, what is your body doing? Where is your body and what orientation are your limbs and your bones? And so you can imagine that having good proprioception is critical for connecting to your body in a general way, and then also in movements and movement rediscovery. For anyone with complete or even incomplete paralysis, this proprioception can be a little bit fuzzy. And so it's really hard to send signals to areas that you aren't feeling or aren't sensing or aren't connecting to. And so you can imagine proprioception, again, is super important if you are looking to access those areas. In addition, tone and specificity can increase with this lack of understanding, this lack of proprioception. It's like your body doesn't really understand what's going on or what's happening. And so it'll just seize and tighten up just in case there's a threat. And so increasing your proprioception can help with tone and specificity in the long term. Specifically, I like highlighting the sensory hotspots in your body. These are places like your hands, the bottoms of your feet, your neck, and your face, which are highly innervated by sensory nerves. And if you think about it too, these are the areas of your body that are sort of at the end of your body, the end of your limb. And so if you can have better information or proprioception about that endpoint in your body, then you're more likely to integrate from the tip all the way up, from your brain and then back down to your tip. So again, hands, feet, neck, and face are all hot spots to work with for better proprioception of your whole body. It's a good idea to do these drills before you head into a movement session. Ideally, you would do them on your own so that you can prepare your own body. But if you need help, of course, just maybe take 5 minutes at the beginning of your therapy session to prepare your body. I recommend you try out these drills right now so that you have this experience in your body and to pull from for the next time that you go into a therapy session. If you don't have time to do it right now, make sure that you save it and come back to it later. You can do these drills in any area that you're looking to improve your proprioception in. So your arms, your legs, your trunk, your back. If you can't reach those areas, you can just have someone help you out. For today, I'm going to show the drills just on my arm because that's easiest on camera. But again, you can do them in any area. Just a quick note, if you have no sensation in the area that you're trying to improve your proprioception, I recommend doing these drills in an area that you do have some sensation in. So that way you can log that experience. And then when you're working with that other area, you can try to replicate that sensation or that sense in your brain as you're working with that area. So you're kind of telling your brain, okay, this is what it should feel like. And then over time, the theory is that that sensation will develop in those paralyzed areas. First, we need to create a baseline awareness of what these areas are feeling like for you right now. That way, when we do our interventions, we can notice a change. So go ahead and close your eyes and just notice what's happening in that area of the body that you're looking to improve. How does one side feel compared to the other? What sensations at all, if at all, do you feel? Is there tightness, tingling, pain? Maybe subtle pressures of where your body is touching a surface. Maybe you have no sensation at all.
Follow along with the chat. Let me know down in the comments. Do you feel anything?
Maybe you just have a visual kind of mapping of what it should feel like. Now let's get into some sensory interventions that you can use to help increase, to kind of dial up that sensation. So first is touch. You can
Touch is important.
And use the palm of your hand or someone else's hand, and you're just gonna gently rub in that area. So rubbing all the way from the shoulder all the way down to your hands. We talked about the hot spots in the hands, and I'll get there in a second. Just the simple act of rubbing skin stimulates the nerves just underneath the skin to give you a better idea of that limb. You can also use some sort of textured surface like a spiky ball or a hairbrush or a comb and run that over the area too. And it's nice to have two different stimuluses, two different types of touch on. Your brain kind of might think, oh, well, that's kind of interesting because that's kind of different from what we did right before this.
Shout out to my terrible grasp.
And then, yeah, make sure that you're getting all the way through your palm. Again, your hand is a sensory hotspot, so we want to make sure that that's engaged. And you can also use like scratching. So if you want to take something a little bit more harsh, like a nail or maybe a comb would even be more harsh. And so you can scratch that area too. Obviously, don't break the skin, but just that little bit of scratching can kind of bring some blood flow to the surface as well. And again, stimulate those nerves that we were talking about under the skin.
Like sometimes you may forget to massage yourself, but I don't know. If you just do it for a little bit, it actually becomes it feels good to get that blood flow into those affected muscles or paralyzed limbs. So it's another reason massage is good. But if you can't get somebody else to get you a massage, you could just give yourself one, right?
Another thing I really like doing is adding some sort of vibration to the limb. So you can do this. You don't need any fancy tools. You can just do this by pounding on the limb. And I'm not going to do any more of that just because it's annoying, but go ahead and continue doing that, just pounding on the limb, bringing that subtle vibration through the skin, down through the muscles, down into your bone. And then I also like clapping because that gives almost like impact through the end joint. If you think about it, would be like jumping, but through your hands. And if you're doing this with your feet, you would just pound your feet on the floor, maybe with someone helping you or doing it yourself.
Right.
Cool. If you want to get fancy, you can use a vibration tool. Sometimes I use this vibrating roller on clients. I'll put it on the hand and maybe on the bottom of the feet. It just vibrates and definitely brings a lot of sensation to the endpoint. Sometimes I'll just have clients hold it. And there's that. If your tone or spasms did increase with any of these interventions, start with some of the lighter interventions, just like petting, rubbing, and light textures. The vibration could have been a little bit too invasive and a little bit too much of a shock. And so your body's response, again, is just to be tighten up.
Let me know if y'all have any like vibrating tools. I don't know if y'all have any of those, but that might maybe like one of those shockwave therapy systems. If you could get that in through your bones, that's another way to get impact and therapy.
To keep the joint safe, just in case. So now after some of those sensory interventions, go ahead and close your eyes and take notice. How does the side that you just worked with, how does that feel different from the side that you did not work with? Hopefully you feel a little bit of something more.
Let me know, chat. Do y'all feel anything?
In that one side, maybe warmth, maybe tingling. Some people describe it as breezy, light. And then if you did feel a positive change, it's definitely worth.
Do y'all feel anything?
Doing the other side. I'm not going to do that with you today, but you can rewind this video and try it out on the other side. We would love to hear what you think about these little drills, these simple drills.
All right, so shout out to that YouTube channel called Zebrafish Neuro. She explained some good exercises you can do just in your chair. You don't have to be at a physical therapist in order to get some good work in. So that's something you can do right at the house. And now I want to jump into some psilocybin microdosing studies that I've seen recently from sidepost.org. And if you're watching the live replay, go ahead and comment down below your experience with psilocybin and magic mushrooms, or let me know if you're interested in experimenting with psychedelics, and of course, at your own caution, responsibly. But I find it interesting to read on the newest, some new articles that I haven't seen before, explaining some of the neuroscience behind the magic mushroom and the psilocybin that it contains. So this is a article from 2016, explaining the characteristics of individuals with spinal cord injury who use cannabis for therapeutic purposes. So this is not the right article. This is cannabis. So we're gonna go and share the correct tab, because that's not the tab that we're gonna actually react to right now. We do it live, folks. So, okay, let's find it. Placebo. There you are, hiding from me. Placebo-controlled study. This is from SciPost, from September 6th of 2022, explaining the placebo-controlled Studies suggest that the benefits of psilocybin microdosing can be explained by expectancy effects. So let's read this article right quick and react to it and see what it's trying to tell us. Anecdotal evidence suggests that microdosing with psilocybin mushrooms offers mental health benefits, but a recent experimental study suggests that these purported benefits may be driven by users' expectations. Findings from a placebo-controlled experiment were published in the journal Translation Psychiatry. Microdosing, the practice of consuming low sub-hallucinogenic doses of psychedelics, appears to be growing in popularity among the public. People who engage in microdosing often do so for potential mental health benefits, hoping the practice will improve their mood, concentration, cognitive function, and even creativity. However, there is currently little, experimental research on the effects of microdosing with psychedelics. And I can say, objectively speaking, that I've experienced um, good benefits from starting microdosing back in about 2020, taking it every so often. Um, I used to do larger doses, and then I found out about the benefits of microdosing it just as a daily cognitive um, boost. It's pretty much helped out my anxiety um, and allowed me to be a little bit more creative as well. So I enjoy the microdosing. So let's find out what it would do for someone who participates in microdosing, such as myself. So, in an experimental study, Federico Cavana and colleagues tested the effects of microdosing with psilocybin, a compound found in psychoactive mushrooms that is commonly used for microdosing. Importantly, the study authors controlled for participant and experimental expectancy effects, which is when the expectations of participants and researchers influence the results of the study. So a bias towards the expected effects. So the researchers recruited 34 participants and 11 women who were already planning to start a microdosing protocol. The experiment involved 2 weeks of measurements. During 1 week, participants were given 2 doses of 0.5 grams of dried psilocybin mushrooms. During another week, participants were given 2 doses of placebo of the same weight and preparation. The experiment was double-blind, which meant that the conditions were organized by a third party, and neither the experimenters nor the participants knew if subjects were given a placebo or psilocybin capsule. Participants completed a self-report questionnaire where they reported the acute effects they experienced with the doses and completed psychological measures including anxiety, positive and negative effect, well-being, and stress. They also completed several tasks assessing creativity, perception, and cognition, and their brain activity was measured with electroencephalography. Uh, Finally, participants reported their expectations for how their mental state might change in various areas. So their brains um, they were told to do a task, and then their brains were measured with this EEG, which then they reported how their mental state was, whether they felt positive emotions or anxiety. The results revealed significant effects on the self-report questionnaire, where participants taking psilocybin reported higher acute effects compared to those taking placebo. However, these results were only significant among subjects who had correctly identified which condition they were in. In other words, subjects who correctly identified whether or not they were taking psilocybin. This suggests that the observed subjective effects were driven by participants' expectations. So whether or not you go into the trial feeling as though you're going to have a positive or negative experience is going to influence whether or not you actually subjectively have an effect that's positive or negative. While the EEG results revealed altered EEG rhythms, the study failed to reveal any positive impact of psilocybin on subjects' creativity, cognition, or self-reported mental well-being. By contrast, a trend in the results suggested that the psilocybin may have hindered performance on certain cognitive tasks. The authors note that this trend is in line with past evidence suggesting that stronger doses of serotonergic hallucinogens can be detrimental to cognitive functioning, for example, by impairing attention and decision making. And of course, this is all being revealed with EEG rhythms and the performance of participants. But let's read further. Overall, the results did not support previous evidence that microdosing improves well-being, creativity, or cognitive function. However, there were several limitations to the study which may impact the findings. For one, the experiment involved a short-term microdosing schedule of 2 doses per week. Future studies should have tested whether microdosing over an extended period may have a stronger effect on mental health. Additionally, the sample was comprised of healthy participants, and it could be that microdosing with psilocybin only produces positive benefits among patients suffering from mental health issues. The authors say additional research is needed to determine whether microdosing truly offers mental health benefits and to gain a clearer picture on its safety. It's interesting because if microdosing psilocybin for a person that has mental health issues already may be seen as more beneficial than taking it microdosing for someone that is already healthy, then why would it not work the same for someone that's already healthy? So this may be all based on subjective reporting, and this is going to be a study that needs to be further studied. But the study microdosing with psilocybin mushrooms, this double-blind placebo-controlled study was authored by Federico Cavana, Stephanie Muller, Laura. Okay, so shout out to the authors of this article and the website, scipost.org. I just thought that was a quick little interesting article about mushrooms, psilocybin, and the effects that could have beneficially for you. If you do already take psilocybin, let me know down in the comments, or if you have in the past, or if you're looking forward to. And that's some neuroscience behind psilocybin, the magic mushroom, if you're interested, and that and the benefits for you. So this one is a study from nature.com, and it's about the neuroplasticity induced effects of psychedelics. So what we're going to do is react to that right now. And shout out to everyone in the chat right now. Let me know how your day is going and what you're doing, what you're up to. So let's open this article and react right now. So this, we're gonna just go ahead and react to the abstract. It's a article that was posted in 2023, and it's talking about the understanding of psychedelic-induced neuroplasticity. So what we're gonna do is actually jump into the intro, which is that recent decades have seen renewed scientific interest in classic psychedelics, which include LSD, psilocybin, um, dimethoxy iodimethyltryptamine or DOI, 5-MeO DMT, methoxy dimethyltryptamine, and DMT, N-dimethyltryptamine, the psychedelic compound in the Amazonian ayahuasca brew. The classic psychedelics have been shown to catalyze relatively long-lasting improvements in mental health after a small number of doses, especially when combined with psychotherapy. In patients suffering from depression, anxiety disorders, and addiction, the benefits of psychedelic-assisted psychotherapy can last for many months or years. Additionally, healthy subjects report increased well-being up to a year after administration of psychedelics in a safe and supportive setting. So this is not microdosing. This is actually going to be a study comparing effects to larger doses. One leading theory of psychedelics lasting effects categorizes them as psychoplastogens, which rapidly stimulate a period of enhanced neuroplasticity, as well as enduring neuroplastic changes. Neuroplasticity denotes the nervous system's ability to reorganize its structure and function and adapt to its dynamic environment. Throughout the lifespan, neuroplasticity is essential for learning, memory, and recovery for neurological insults, as well as adapting to life experiences. The theory that psychedelics open a window of neuroplasticity would explain how long-term effects outlast the drug's presence in the body. And it is also attractive because disruptions in neuroplasticity are present in mood disorders and addiction. So this is going to show us the long-term enhancement of neuroplasticity and neuroplastic changes for people throughout your life, which is going to be essential for continuing to learn, retaining memory, and recovery from neurological injuries. And this is also going to show us how long-term effects can be shown in the body and the benefits that it'll be shown, the benefits that'll be shown, neuroplastic benefits that'll be shown present for people that have mental health disorders. So neuroplasticity can be investigated at multiple levels of analysis. At the molecular level, it comprises changes in gene and protein expression, as well as post-translational modifications. Of particular importance is brain-derived neurotrophic factor, or BDNF, a neurotrophin that regulates neuronal growth and synaptic plasticity. Changes in gene and protein expression give rise to morphological changes, including the formation and modification of synapses and dendrites. In particular regions, most notably the hippocampus, neuroplasticity also comprises neurogenesis. These processes modify neural circuits, ultimately manifesting in learning, memory, and changes in adaptive behavior. Neuroplasticity is crucially active, dependent at the cellular level, which translates into experience dependence at the level of cognition and behavior. People who learn both passively and actively from their experiences, adjusting patterns of thought, emotion, and behavior. So in order to effectively harness the potential of psychedelics, it is imperative to understand how they affect neuroplasticity, as well as the clinical relevance of these effects. In the present review, we first evaluate the available evidence concerning whether psychedelics enhance neuroplasticity. We then discuss where in the brain this likely happens, what doses are capable of this, how long this effect may last, and whether they have meaningful consequences for emotion, cognition, and behavior, as well as therapeutic use. Finally, we discuss the advantages and challenges that psychedelic-induced neuroplasticity presents and identify important directions for future research. So we're gonna just pass on from the 3 articles talking about if psychedelics enhance neuroplasticity, if psychedelics enhance how it enhances neuroplasticity, and where in the brain it actually enhances neuroplasticity. And we're going to jump to the conclusion, findings from the study. So the significant progress has been made toward understanding how psychedelics affect neuroplasticity. Data thus far supports the theory that psychedelics stimulate dendritogenesis, synaptogenesis, and the upregulation of plasticity-related genes in a 5-HT2A receptor-dependent manner, affecting the cortex in particular. The window of neuroplasticity appears to open within a few hours and may last a few days. Although neuroplastic changes occurring during the time may survive for at least a month. Because neuroplastic changes occur in an experience-dependent manner, experienced people have during this time may have a greater psychological impact than they otherwise would. Future research should attempt to confirm preclinical findings in humans, clarify optimal doses and specific neuroplastic effects for different psychedelic compounds, and further explore the consequences of psychedelic enhanced neuroplasticity for both patient groups and healthy people. So, the upregulation of the 5-HT2A receptor is the part of the brain that it affects in the cortex. And so we've found that psychedelics does enhance neuroplasticity, and how it does it is it creates neuroplastic changes which occur in the brain, and this is affecting the neuroplastic this is affecting specifically your neuroplastic changes by optimal doses for which is going to depend on the compound you take. So neuroplasticity for both patient groups that were tested were healthy, and so they remained healthy and experienced beneficial effects. So that's an article that I found interesting because compared to the last article we read, that one is more positive about long-lasting. Well, it's showing that long-lasting and higher doses are going to affect your body positively compared to microdosing, and that's clinically been shown. So we're going to react to Mr. Medical. He's talking about medicinal cannabis and neurodegeneration. So I found this video interesting. So let's go ahead and react to it.
One of the commonest questions I get asked about in the clinic is the role of medicinal marijuana or cannabis and its role in Parkinson's or dementia or any of the degenerative diseases of the brain. And the truth is that we probably don't know enough about medical marijuana to be sure as to whether it may have benefits or may not have benefits. But that is really the edge of the research that people are doing right now. We know that a thing like cannabis, it actually is made up of lots of different chemicals. And it may be that somewhere amongst those chemicals, there is going to be something that is useful for some of the features that we see in degenerative diseases of the brain. Typically, people will be familiar that cannabis can cause relaxation, a reduction in anxiety. And we know that anxiety is a very common part across all of these degenerating diseases of the brain. So you can imagine it being helpful there. And similarly, in Parkinson's, for example, where we see people with tremor, we know that tremor is often made worse by anxiety. So the idea of a drug like cannabis helping with things like anxiety or tremor, or indeed helping to relax someone and get better sleep, is something that we could easily consider. But at the moment, the state is very simple. The research that has been done to date, looking at various aspects of the treatment of Parkinson's disease and related conditions with cannabis, has really shown no benefits for the use of cannabis, and actually quite a high rate of problems, side effects. And those side effects can be demonstrated in a number of ways: becoming too sleepy, becoming confused, hallucinating, dropping the blood pressure, becoming unresponsive. So they're very serious potential side effects. So before anybody considers using street cannabis to help their symptoms, I think they really need.
Let me know if you experience those negative effects, sleepiness, etc., from medical cannabis, marijuana, or if you take it recreationally and you find it positive in your life.
Need to consider things very, very seriously, and ideally go and discuss them with your specialist.
All right. So that article was not very positive and pro marijuana for those, and that was Dr. Or Mr. I should say, Simone Lewis. So this guy, Professor Simone Lewis, he's a teacher apparently, with credentials unknown. This was also 5 years ago, and so studies may have came out in disagreeing or actually proving what he has said to be true or false. So that's what we're going to go ahead and react to right now. A couple articles explaining whether or not Mr. Professor Simone Lewis is explaining cannabis in the right way to us, although 5 years ago, or whether or not he was completely wrong about his analysis of medical cannabis. So this is article is explaining the cannabinoid function in learning, memory, and plasticity. And we're going to go ahead and read the abstract, which marijuana and its psychoactive constitutes induce a multitude of effects on brain function. These include deficits in memory formation, but care needs to be exercised since many human studies are flawed by multiple drug abuse, small sample sizes, sample selection, and sensitivity of psychological tests for subtle differences. The most robust finding with respect to memory is a deficit in working and short-term memory. This requires intact hippocampus and prefrontal cortex, two brain regions richly expressing CB1 receptors, animal studies which enable a more controlled drug regimen, and more constant regimen. Is it regimen or regimen? I've always have struggled with that word. Regimen, and more constant behavioral testing have confirmed human results and suggest, with respect to hippocampus, that exogenous cannabinoid treatment selectively affects encoding processes. This may be different in other brain areas. For instance, the amygdala, where a predominant involvement in memory consolidation and forgetting has been firmly established. While cannabinoid receptor agonists impair memory formation, antagonists reverse these deficits or act as memory enhancers. These results are in good agreement with data obtained with electrophysiological recordings, which reveal reduction in neuroplasticity following cannabinoid treatment and increased plasticity following antagonist exposure. The mixed receptor properties of the pharmacological tool, however, make it difficult to define the exact role of CB1 receptor population in memory processes with any certainty. This makes it all more important that behavioral studies use selective administration of drugs to specific brain areas rather than global administration to whole animals. The emerging role of endogenous cannabinoid system in the hippocampus might be to facilitate the induction of long-term potentiation, the encoding of information. Administration of exogenous selective CB1 agonists may therefore disrupt hippocampus dependent learning and memory by increasing the noise rather than decreasing the signal at potentiated inputs. So we're going to get into the neurology of cannabis after this article now, and look at some characteristics of individuals with spinal cord injury who use cannabis for therapeutic purposes. So now let's talk a little bit about how spinal cord injury patients or people living with spinal cord injury are affected by marijuana or medical cannabis, medical marijuana. What do you call it? Let me know. Background. People with spinal cord injury, SCI, are assessing cannabis for therapeutic purposes, CTP. So cannabis therapeutic purposes, the use of which has been legalized in more than 20 states. In the past, illicit marijuana use had positive correlations with other health risk factors. It is not known whether to access to CTP or cannabis therapeutic purposes has shifted patterns of use and altered health outcomes. To describe self-reported patterns of CTP use among individuals with spinal cord injury and correlation with health, behavior, and health indicators. So the method used was secondary analysis of data from a cross-sectional study involving community-dwelling individuals with chronic spinal cord injury and neurogenic bladder and bowel at least 5 years post-injury. Data was collected via structured interviews, so self-report analysis. Results were that 92.2% of the current sample lived in the States at the time of the study, permitted the use of CTP, and 22.5% reported using CTP at least monthly to relieve pain, or 70%. And spasticity, for spasticity, 46% of those 54 participants, 52.7% were daily users, whereas 23% of non-CTP users endorsed having prescriptions for at least one opioid-based medication. 38.1% of CTP users did so using that CTP use does not mitigate opioid use. Users were more likely to be single and live alone, report more bladder complications, and perceive their psychosocial functioning as more compromised than non-users. So the conclusion, a relatively large percentage of individuals with chronic spinal cord injury appear to use CTP or cannabis on a regular basis. Results suggest that they may be more vulnerable to complications and to risk factors for substance use disorders in spinal cord injury, such as social isolation. Although the the generalizations of these findings is limited by the sampling strategies and the eligibility criteria of the larger study, cannabis use should be assessed and considered when planning health interventions. So basically what this is telling us, guys, is that medical marijuana after spinal cord injury may lead to more complications and risk factors, such as substance abuse, social isolation, bladder complications, and perceived psychosocial negativity, self-reported. So this is also going to affect your health, basically. And so now we're going to talk about the pain prevalence, and substance use of spinal cord injury users that use cannabis. So we're gonna skip the article here and the methods, the procedures, and the participants and all. And we're gonna get to the findings of this article here. It's an interesting study and interesting information that they gave us. So this study replicates results from previous studies in finding that almost a quarter of individuals with chronic spinal cord injury self-report being users of cannabis. Pain, or CTP. Pain tended to be the most frequently cited reason for use, followed by spasticity, anxiety, and other non-specified uses. The current study further suggests that CTP or cannabis users differ from non-users along distinctive demographic and functional domains. CTP users endorsed greater disruptions of daily life by pain, and CTP may represent a complementary route to pain management for the majority of its users. Extending the literature, the current data shows that the use of CTP did not mitigate prescriptions for other potentially SCI related pain medications, but rather appeared to fulfill a supplementary function. So instead of completely getting off of drugs or opioids, people continue to use cannabis, which is not often what I hear when asking people with wheelchairs if they smoke or cannabis. They usually tell me that they get off drugs, or it replaces things like baclofen and other drugs that they may be prescribed for certain reasons. So because cannabinoid use by itself carries risks for adverse events, clinicians should encourage patients to disclose their patterns of CTP use to allow close monitoring for adverse drug or drug interaction effects. According to the current study, more than half of the CTP users endorsed daily use of cannabis. However, frequency of use did not match self-reported disruption of daily activities by pain. First, as pointed out earlier, individuals use CTP for more than one reason, including factors unrelated to pain and spasticity. Second, this lack of a relationship may reflect differences in dosing, route of administration, or compound content, as there was great variability in frequency of use, even among those participants who indicated severe disruption of life by pain. Finally, a lack of relationship between disruption of activities by pain and frequency of use of CTP may mirror the impact and effectiveness of other existing regimens. There we go. Regimens, got the word down, guys. Regimen. CTP users in our study reported more bladder complications and fear of urinary accidents than non-users. Previous studies of complications in SCI have suggested that a history of alcohol problems with subsequent abstinence is associated with an increased risk of urinary tract infections. Hawkins and colleagues related these bladder complications to histories of poor self-care and continuing deficient self-management. Our data suggests that the health behavior management of individuals with current CTP use does not significantly differ from that of non-users, yet users appear to experience a higher rate of complications. While there are studies on the role of CTP in managing urge incontinence and multiple sclerosis, only 3 participants in the present study linked their CTP use to bladder management. Conversely, there are currently no data available that would predict bladder complications from CTP use, and adverse events related to CTP may differ in aging individuals with already chronically compromise central nervous system functioning, because other studies have shown that cannabis use tends to correlate with a history of alcohol and other drug use, which were not assessed in this study. It is unclear whether the reported complications reflect the effects of other substances. So these users are reporting more bladder complications in this study, but typically the users have history of alcohol and other substance abuse, which also increases your risk of having urinary tract infection. And so this is gonna also lead to, poor self-care. These bladder complications are a result of poor self-care, I should say, and a lack of self-care, pretty much. People who do smoke cannabis tend to report that they are more likely to fear incontinence issues, and have more trouble managing bladder. And so this use of cannabis also will correlate to having a history of alcohol and other drug use, usually. And it's unclear whether we know whether other drugs are the reason that the cannabis use is affecting them negatively. So in terms of their psychosocial functioning, cannabis users were more likely to be single and live alone than non-users. Like non-users, users who had a primary caregiver reported a generally good relationship with him or her. However, the current assessments were focused on instrumental caregiving relationships and did not probe whether individuals assessed emotionally meaningful relationships. Interesting that cannabis users were more likely to be single and live alone. So does that mean that if you smoke, you're more antisocial? And then they're saying that pretty much non-smokers of cannabis tend to have more positive relationships with their caregivers following spinal cord injury. So this is instrumental on whether or not you should decide to engage in cannabis following spinal cord injury. But the relationship is, of course, user dependent. So, some people may smoke cannabis and get along better with people rather than be more antisocial, or want to emotionally have relationships, meaningful relationships. So recent conceptualizations of substance use from a behavioral science perspective have emphasized a crucial role for lack of social support. In these models, the progressive narrowing of alternative, meaningful relationships and activities is characteristic of situations that give rise to and support the use of mood-altering substances. Accordingly, relationship status has been shown to correlate with increases in the risk for the use of mood-altering substances in spinal cord injury. So, in addition, one might speculate that increased anxiety after spinal cord injury, including fear of bowel and bladder accidents, could lead to a long-term spiral of social withdrawal, a narrowing range of activities, which with concurrent lack of distraction from pain, and a general perception of a decreased ability to master everyday social roles. Based upon these findings, future studies should focus on the link between social support, anxiety sensitivity, and pain, and cannabis use in spinal cord injury. The current study was limited by its relatively small sample size its cross-sectional and descriptive nature, and the lack of information about past history of substance use and mental health history and related measures. Participants were not recruited to participate in a study of cannabis use in spinal cord injury. Rather, recruitment occurred for an ongoing large investigation of the relationship between bowel and bladder functioning and QOI. Thus, the characteristics of the sample reported were directly affected by the inclusion criteria of the study in the context of which these data were collected. So, example, chronic spinal cord injury and at least 5 years post-injury with neurogenic bladder and bowel. Because of sampling strategies, more than 90% of the current participants were recruited from spinal cord injury research registries and spinal cord injury clinics, and the eligibility criteria of the larger study, the current sample may not be representative of the population of individuals with spinal cord injury as a whole. It may be that some individuals with spinal cord injury who use cannabis for therapeutic or recreational purposes were reluctant to admit their use, particularly those 19 individuals who lived in states that had not legalized the use of cannabis at the time of the study or to participate in clinical research study. Thus, it appears likely that the figure of 22.5% is actually an estimation of the prevalence of cannabis use for patients with living with spinal cord injury. It will be important for future studies about CTP to gather more information, including duration of use, perceived effectiveness of use, and many other factors. As such, both qualitative studies as well as clinical research that incorporates objective assessments of health variables will be important to provide insights into who uses cannabis, how it is used, and why it is used, and such better inform the clinical conversation that needs to occur around the issue. So I'm going to give a little bit of a personal bias here. I find cannabis particularly beneficial in my life, especially during times of spasms. I have episodes where I get tight, and sometimes the spasms are during the winter are very bad and very aggressive, I should say. So sometimes a hit of marijuana, CTP, cannabis, alleviates that effect that I feel from that annoyance of constantly having to worry about spasms, and it allows my body to relax in that way. But it has other effects as well, as we've read, as far as your relationship to those that take care of you, your caregiver, and the effect that it has neurologically on your bladder and your bowels, and then how your general how you generally feel, I should say, as far as socially. So it's important to experiment responsibly and find what's best for you, whether it's marijuana or CBD products or psilocybin or any other drug that you feel alleviates those fears and pains that you may have and allows you to express yourself in your most positive and best way that you can. So those are pretty much all the articles that I'm going to react to for this episode. Guys, I appreciate everyone that is still tuned in right now to the chat and also the live replay. I'm going to react to some chat right now. BMU Luck says, I missed what about psychedelics? Oh man, you're gonna have to go back some. We talked about a whole lot, brother. We talked about a whole lot. Only time I wasn't in constant pain was after eating mushrooms. So we got somebody here says that they experience pain relief after eating magic mushrooms or psilocybin. So there's one person that has experienced positive effects. And then I gotta go. I didn't hear if you responded. Something to look into, though. I think psychedelics are one of, if not the best medicine for the vast majority of spinal cord injury. Take care. So I agree, brother. If people with spinal cord injury do want to experience pain relief or a different way of healing, that's one way you could experiment. Of course, take out your own risk and do it responsibly, right? So I appreciate everyone that was tuned into the live chat and everyone that is watching the live replay. We're currently at an hour and 25 minutes. So if you're still watching this, that is absolutely insane. Thank you. I love you so much for the support. In this episode, guys, we discussed proprioception, psilocybin, and a microdosing study, cannabinoids, and the neurogenesis and neurodegeneration that all these can help you with. And so I just want to thank you again for tuning in. And I want to tease the next episode. I'll give you a little teaser here in episode 5 coming up. We should have a guest, hopefully for you guys, and someone to give just a different perspective on their world and to give some insight into how they live. So stay tuned for that, guys. It's going to be a good one. And then, of course, I'm going to be doing this once a week, hopefully. And I want to get on a schedule where I'm doing it more and getting you guys constant content. But for right now, every Friday, we've been going live for the past couple weeks. So thank you for continuing to show your support, and for everyone that's been giving me positive feedback or negative feedback. Either one is accepted. Thank you either way for staying tuned with the show. If you could, while you're here, just go ahead and leave me a comment. That would be greatly appreciated. Give me some feedback. Drop a like and share. And let's get this video to 100 likes at least before the next Friday drop episode. That would be amazing. So amazing. But again, there's the description box down below if you want to show support in any other way. I have links to my Patreon. Shout out to all the new Patreon subscribers. New content on there. And then you could also support the podcast and the show by hitting that Cash App and sending something if you feel for it, if your heart is led to it, of course. No pressure. And then I just want to ask you guys before I go, what was the most interesting or helpful part of this episode for you? And to just go ahead and let me know down below or on Spotify. You could leave me a 5-star review and let me know how you like the show. And yeah, I'm out, guys. I love you so much. Stay blessed, and I'll catch you later. See you on the next one, guys. Ladies and gentlemen, we're out.